Welcome, everyone. Welcome to this month's HSPN webinar for Ontario Health Teams. The first thing we like to have everyone do is to open up the chat box and type to everyone who you are and where you are joining us from. Today, we have a fantastic lineup to talk about engaging in co-design in Ontario Health Teams. So appreciate that. If everyone could maybe advance the slide that shows for everyone to join in. Perfect. Set the response to everyone. Here we go. Fast and Furious. Lauren Karuna from Elgin OHT. Marcia from the School of Rehab at Queen's. Jillian Fennick was the first one in from Couchiching. Emily Porshak from Oxford OHT. Jennifer from Lakeview OHT. We have people from all over, all corners of the province. Sometimes we have people joining in from other provinces and internationally, but we really have many. Western York region again. Laurie Snow from VON Nova Scotia, as I said, other provinces sometimes. Celine Janvier from Xavier from U of T. Laura Harild from the Mississauga Ontario Health Team, who are participating today. So we even have our speakers that are joining in. So please, nice to see you again, Monroe, who's here every month, I think. I'm not sure you've ever missed Monroe. And Kaylee McMillan from Berrien area. Please continue to type into the chat who you are and where you're from joining us. It's really lovely to hear from people from all over the province, and we have a sense of who's participating. And we engage and encourage you to continue to participate throughout today, as I think today's topic is really a very engaging one. I'd like to start off with the land acknowledgement. I'm speaking to you today from the University of Toronto, and I'd like to acknowledge that the University of Toronto operates on land that for thousands of years has been the traditional land of the Huron-Wendat, the Seneca, and the Mississaugas of the Credit. Many of you are joining us from many different parts of Ontario who are speaking from different territories that have different heritages and ancestries. Currently, the University of Toronto is still the home to many Indigenous people from across Turtle Island, and I'm very grateful to have the opportunity to work on this land and to welcome you from all of your lands across Ontario and across Canada, as I've seen, maybe elsewhere as well. We are here today talking about this Learning Health System Action Framework, and we've actually been on a series here. This is the fourth in the series. The first one, led by John Lavis, Maureen Smith, and Rob Reed, talked us through this entire framework and how it applies. And it was really a great opportunity back in April. I encourage, if you didn't see it, that you go back to that original one to get a sense of the entire framework and how it fits and how it can support change and improvements in the health system. Within there, we have these different gears. So the first one is around analytics and data, population health. We did that in May, had a number of OHTs presenting for that day. Then we did evidence synthesis in June. I encourage you to go back and look at that. And I see post-event, that's actually one of the highest viewed events so far. Over 350 have gone back to view that one. We had representatives from a number of Ontario evidence and synthesis shops. Today, we're in this central and I think focal gear for patient caregiver and provider co-design. On the next slide, we talk about some of the details of this slide, of this gear, the Learning Gear 3. And this is where, we have it in the middle because I think it all comes together here. And it's essential in every element of the program, but particularly here in co-design. This is talking about direct engagement and co-design with patients, caregivers, and care providers, as well as broader community members impacted by the health problem that we've identified, alongside those who can actually move the design services towards successful implementation. So thinking about how do we think about co-design in a way that will help us in the next step, which is implementation. We want to co-design the things that fit and achieve the goals of patients, family, caregivers, and also are those things that help support providers, and providers can support this work. So some of the questions that you might be thinking about when you're doing this co-design work are, what are the user-centered conditions? What considerations are most important? How can technology be used? And how do requirements differ for equity-deserving groups? How do we engage and balance power? And what are the feasibility constraints about what we can actually do? So those kinds of questions we're really looking to delve into in this co-design work. Many different organizations, groups, affinities, meaning sort of where people are coming from around this space, from design experts to clinical programs, health informatics programs, patient family caregiver councils, community groups, health system leaders, providers, many people being involved in this co-design work. It's really quite important and essential. So we're going to have a fantastic lineup, and I'll introduce them in just a moment. But just before introducing our speakers, I'd like to engage people to find out how many people are joining us for the first time, or whether you have joined us previously. So have you joined us previously, or are you joining us for the first time? And look forward to hearing people's responses. I see we have Kim Loringer has joined us from Kenora and Treaty Number 3. We've had conversations with the people up at All Nations in Kenora. Welcome, Kim, and all the others that have joined us today. So the few people still responding in here, I think that's petered down now. So maybe we could end the poll and share with everybody that typically I will say on this event, we have about 70% returns, 70 to 80% returns, and 20 to 30% new people. So in doing this co-design, this has attracted a considerable new audience to this activity and this event. So welcome to the Health System Performance Network monthly webinar for OHTs. I think you're really in for a treat today. And I'm really keen to hear from you about your work, and all of the speakers today here keen to hear about you and your work in Ontario health teams as you support that work. So who do we have up today? We have quite a range of participants. So first off, we have Dr. Kerry Kuluski. Kerry Kuluski holds the Dr. Mathias Gysler Research Chair in Patient Family-Centered Care at the Institute for Better Health, Trillium Health Partners, and is an associate professor at the Institute for Health Policy Management and Evaluation, U of T, where I am based as well. And she works in partnership with people who use care design to understand their experiences and improve how we deliver care. Kerry is also co-author on that framework, along with Rob Reed, myself, and some others. And is really central to that work. Then we're going to hear from key representatives from two of the OHTs. So from the Mississauga Health OHT, Dipti Purbhoo, who's the executive director at the Dorothy Lay Hospice in Mississauga, Dr. Laura Harild, who's clinical co-lead for Ontario Health Central Region and medical director for palliative care at Trillium Health Partners, where she's been since 2011, and Frances Henderson, who's a caregiver advisor. And you're probably catching on, this group is going to talk about palliative care. So caregiver advisor to Mississauga Health, particularly as it relates to palliative care, and has been a volunteer in the hospice and has her own personal experience that she really brings to this co-design and her participation in the Ontario Health team. And then we'll hear from the Mid-West Toronto Ontario Health team, both Yasmin Sheihkan, who is the vice chair and a chair of the Patient Caregiver Advisory Council, and Ed Rost, who's director of corporate planning and has co-led or led the mental health working group. And so their example will come from co-designing with mental health. So we have a lot of material coming today. Look forward to learning from all of these folks and also to engaging you. So why don't we just start off with a couple quick polls before we go to Kerry. The first one being, to what extent you have engaged in co-design. So if we have the poll up, we can find out whether it's been not at all, a little, 1 to 3, moderate, 4 to 7 types of events, or a lot, and get a bit of a sense of how much and how often and frequently people participating today have participated in co-design. So thanks for joining in. Lots of responses still coming in. So we'll just give this just a moment, try to get a sense of the participants today and how people have joined Okay, it's petering out a few more, and maybe there we can share at this point. Almost most people have responded in. So we hear that there's about 20% or 1 in 5 have not actually engaged in co-design yet. So we're going to come out of here with some skills and tactics about how to do it really well. And just over 50% have done a little bit of this engagement in co-design, 1 to 3 events in the past year. 20% again on that higher end, and a few, 7%, many activities, so a lot. We have one last poll before Kerry starts off, and so we can come back now and have a look at this one. And for this one, you can check all that apply and how you approach co-design. Do you do it by reviewing models, so more of a consultation type process? Do you have ongoing input? Do you run big, many stakeholder in co-design events? Or if you have, completely other approaches, we'd really enjoy having the opportunity to see and hear from you in the chat what some of those other approaches might be. So let's see. Reviewing care models, that's the kind of consultation, bringing it back to people. Ongoing discussion through working groups, so it's a regular contribution. Or how many of you actually have like all-day co-design events? Don't have to be all day, half day, several hours. More about the idea that we're going to set aside time and have a very focused activity around co-design. And so again, you can choose multiples here if you do many of these. And I see we seem to have slowed on the people, so now we could share this back out. Okay, so amongst the people that are now, it's actually interesting to see that almost everybody, 93% of the people who are responding here, use co-design in ongoing discussions and have input into those care models. So that's through participation. I think that's amazing that 93% of the people who are responding here do that. Second to that is bringing stakeholders together for significant events, about almost 60%. And then 40% having this kind of consultation model, reviewing and other approaches. A few people putting in that they have other approaches. So I see that there's a couple, Patrick Van Rooyen, identifying attending events where you can connect with the community and learn how they navigate the system. So it seems like almost kind of going out and reaching out into the community on that behalf. That's also, I think, a very, very strong, and meeting people where they're at. To Christine's question about the polls, when we post the slides online afterwards, the polls are embedded in place of the questions. So the poll results will be embedded. And I appreciate, so a couple smaller scale engagements, specific projects, and go ahead with that from Sarah Good. So thanks, everyone. We have a bit of a sense now. We can bring the slides down, the poll down, and move on to the next slide, where I think I get to turn over to Kerry Kuluski, Dr. Kerry Kuluski, my colleague in many ways, and my mentor in this space for sure. Kerry, go on ahead.
Thank you so much, Walter, and so great to be here today to talk about one of my favorite topics. And before we dig into some specific examples from Ontario health teams, we thought it was important to review some co-design fundamentals. And whether or not you're new to co-design or have been doing this for a long time, it's really great to sort of revisit these fundamental principles so you can be really intentional about the co-design work that you're doing with your partners. So we'll hit on what is co-design, because there's so many definitions out there, and then we'll look at why it matters, and then I'll pull through a couple of practical examples of my own. So when we look at a recent paper by Thurborn, they define co-design kind of in these 3 buckets. So co-design is a process for developing solutions to typically complex problems where you need to get, a number of different collaborators together to dig into something to try to make something work better or design something like an intervention. It privileges lived expertise. So ideally, whatever you're working on, you're going to work with people that are directly impacted by that problem that you're trying to solve for, in addition to people that have that power and interest in making a change, that are able to implement what you're designing. And it also represents a shift from consulting with partners to more equitable decision making. So it's kind of, if you think of a continuum of engagement, you're moving from sort of asking people questions, getting feedback, doing surveys, etc., to actually coming together as a group to think through and solve problems together. Next slide. And to break it down even more simply, we could look at Sanders' work from 2002. They talk about 3 approaches to interacting with people. So they say, do, and make. So say is about listening to what people have to say. Do is watching how people might use products or services. And make is where sort of co-design fits a bit more concretely. It's about coming together in creative workshops and discussions to explore things and make solutions. And of course, all of these things kind of combine together when you're doing co-design work, but it's another framework to help situate what we're doing and the different degrees of engagement. Next slide. So we can also look at co-design as a form of engagement. And of course, there's a continuum of engagement where you go from consultative practices to more kind of embedded and closer work together, decision-making, et cetera. And looking at Paula Rowland and Jennifer Johansson, they have a chapter in a book on that was edited by Brian Hodges on compassionate care. And I really like how they talk about engagement as framed in different ways. So engagement can be framed in an instrumental nature. And this is typically how we think about engagement. It's action-focused, it's committee work, doing co-design activities where we're really striving for a tangible product or a tangible outcome or something new or a redesign of something. But engagement is also importantly framed in a democratic form. And so presumably when we come together with the community, we will agree that they have a right to influence healthcare. So the democratic piece is another driving force. And we could also think of engagement in a narrative form where it's about learning, unlearning, relearning, sharing, and coming together. So in terms of co-design, you could see that all of these things kind of come into play. So the instrumental part of co-design is the activity that we do. The democratic part of co-design is honoring that when we come together, we believe that people have a right to influence their healthcare and to shape what that looks like. And also that we engage in narrative forms of learning together and challenging our assumptions as we work together. Next slide. And just to put the phases of the work together in a very simple form, what I like to revisit and share when I do these types of presentations is really reinforcing that co-design isn't just bringing anyone who's available together, although sometimes if we have a short timeline, we might rely on sort of the partners we usually connect with, which isn't necessarily a bad thing, but it's really important that we're going to be working with people that are actually affected by the problem that we're seeking to fix. So we'll hear from a group focusing on palliative care in Mississauga. And so, working with people that have had an experience in that space will be critical. But also in an institutional setting, we know that there is power differences in terms of implementation power. So we'll have to, it's important to ensure when you do co-design activities that you're working with people that are invested in implementing what you're co-designing and keeping that in mind as you do your work. The first phase, which is sometimes neglected and skipped over or done a bit too quickly, is the relationship building phase. To really get to know the community you're working with, learn what they're interested in, what their priorities are, and also what they need to effectively participate in the work that you're doing. There's obviously the activity phase of the work we're doing together. It might be a workshop or a world cafe or a journey map that we're creating together. That's considered the activity phase. And the other piece that is sometimes neglected or not focused on enough is the looping back and the ongoing engagement phase. So when you finish your co-design activity, it's about looping back with the group that you've engaged with to talk about how their ideas were taken up or maybe not taken up and why, or what pieces of their feedback were used or not used. and also continuing to build the relationship. And there's likely work that you continue to do together as you evolve the intervention or process improvement that you've been working on. In a true learning health system, as Walter sort of showed at the beginning, you're always kind of in that loop of evolving and improving over time. And so that co-design and engagement is a little bit more fluid throughout that process as you continue to work together to evolve and improve the services that you have. Next slide. I pulled this from a recent paper from KISS and colleagues and made just a few adaptations. This more fully fleshes out all the stages of co-design. What I showed you in the last slide was just a simplification of this, which fleshes out the steps a bit more. So it starts with engage. So again, building relationships and taking time to understand the problem from the perspective of the community that you're working with. Planning the work together. So the stages of work, the logistics of the activities, the methods you're going to use, the goals that you have to make sure that everyone's roughly on the same page going forward. And then you explore, so you dig deeper into learning about people's experiences and setting priority areas. So this might be done kind of in advance of a co-design activity where you're doing some additional engagement or interviews or working groups. And then you move into the development stage where you're actually creating, maybe it's a process improvement, or you're taking something that exists and you're working with your partners to tweak it and with your community to make it better. And then there's a process of narrowing things down and deciding how to refine it and focus it. And then, of course, ideally, you turn those ideas into action, and that could take some time. And as the system changes around us, and the complexity of the system is always there, it's important to be very nimble in how we're situating the work that we're doing. Next slide. And so this is a really good piece by Sendra. It's just recently hot off the press, and they get into the ethics of co-design. And this is based on participatory action research projects that were conducted in the UK, in addition to a literature review, where they took the 6 principles of fair consultation that are used in the UK and fleshed it out further into 10 co-design principles that we can think about as we do our work. And I think this list is always good to go back and revisit as you're engaging with your communities. So first and foremost, we have to apply collective thinking. So going from thinking as separate individuals to thinking as a group. Of course, we have diverse perspectives, but really thinking about, are we all driving in the same direction? Are we really working together as a collective community to solve the problems that we see in front of us? There's the creation of partnerships where you're taking the time to connect with people and find participants and partners for the work, knowing the population and the context that you're working in. So knowing any histories of the population, any structural marginalization that they may have or continue to experience, and knowing sort of who are the people that are really impacted by the problem that you're seeking to solve for, and getting to know, taking the time to get to know that population. And that will help you address power imbalances. So when you're initially connecting with the population you're going to be working with, knowing how do they want to engage, what will make them feel most comfortable, what do they need to do to prepare, and also to the research team, other system partners, what do they need to do to prepare to create an enabling space so everyone can participate. So there's a bit of work, especially if you're new to co-design, to dig into to get to know how to create spaces for people to share ideas. Empowering people to participate. So there might be some skill building for all types of partners. To get some awareness on how to do this work, using inclusive events and language, or having inclusive events and using inclusive language, thinking about where you're going with the work. So do some people stand to benefit while others will lose out? And it's really important to apply equity principles. So how can we all benefit from the work we're doing? Timing and resources, and also starting before decisions are made. Sometimes we might consult people after we're kind of pretty far along in the project. So ideally, we're, building our communities to work with, so they're involved in the decisions along the way in the co-design process. Next slide. And another set of 4 questions, which might be helpful as we ready ourselves, as well as our organizations, to do co-design work, is to really think thoughtfully about the positions that you hold and how that might impact others. How you make others feel, and trying to pay attention to body language and how people are receiving the energy that we bring into these spaces. Asking, am I creating a safe space? And what do you need to do to create that safe space? And also, is the organization or the context we're working in ready to make the change that we want to achieve? And of course, there's some more tactical pieces you can do to really think about, how you can create a safe space for others. And one really important piece is knowing the backgrounds of individuals that are coming to the group and the resources that they need to prepare for that co-design activity that you're doing or the ongoing engagement. And also making sure that you're providing space for people to contribute in various ways. Long pauses between questions, giving people time to reflect, and then sharing, maybe writing down responses, sharing openly the responses. And if it's on Zoom, the chat function is helpful. Maybe providing space after a meeting for ongoing reflection, and offering one-on-one opportunities to connect further with people, particularly for those that might want some extra time to digest what's happening and provide feedback after. So those are ways to create some safety within the spaces that you're working in. Next slide. And why does it matter? Next slide. And so looking at the work by Steen on the benefits of co-design, and this is coming more from like the service design literature. So you'll see like the verbiage is a bit different, the use of the term customers and users, but we can think about, patients, families, communities. Benefits are for the project. When we're engaging with our communities to design our project, we're going to have different viewpoints informing the work to make it ideally more inclusive. It will be a more creative process. We'll be able to figure out what definitions to use, how to describe things, so it's a little bit more of an enabling context. And also there's benefits for people that are going to be using the thing that's co-designed. Ideally, there's going to be a better fit between the service and people's needs and the actual experience. We're going to close that gap. And also the organization. By doing co-design work, you're creating spaces for innovation. You're training people how to think differently, how to work with partners, how to challenge their biases. So just the sole purpose sometimes of co-design, or one of the key purposes, is really to learn how to work together. Ideally, you're going somewhere with this work, but a key benefit is learning how to work with different partners and think differently than the status quo. Next slide. And also it helps us to move from technical to adaptive solutions. So on the left here, there's a differentiation between challenges that are technical in nature and then challenges that are adaptive. Technical challenges have like a pretty clear-cut solution. So say, for example, you have a simple hip fracture, there's a protocol that you follow, the surgeon is in place, you have a whole pathway that's lined up and you're ready to go. When it comes to an adaptive challenge, there's no clear answer to the problem that you're looking at, and it requires lots of perspectives. It requires maybe working across organizations. And so we can think about co-design work as being like an adaptive challenge, and we have to work on our adaptive capacity to work together to solve these challenges. Next slide. I'll have to speed things along. And also co-design is a vehicle for collective impact, which ultimately the OHTs and the system is trying to achieve. It's an intentional way of working together to solve complex problems. And also we can't do this as single individuals or single organizations. It requires coming together across different people and organizations and communities to really create some meaningful change. Next slide. So again, very quickly, I'll probably just walk through one of these examples because we're a bit short on time, is to talk a bit about my own personal experience in two research projects, which has very different outcomes. One's still in progress, but I've had a chance to reflect on what made it work and maybe why did things go in a different direction than expected. The first one is about addressing hallway medicine, and then there's a patient experience strategy that we're working on. So this will look familiar. This is the Learning Health System framework that Walter has been showing across the HSPN webinars, and at the beginning of today's session, is that, well, you know, in our ALC study that we did with patients, caregivers, communities, and providers, we started with looking at the population. So if you click the first click, this will come up. I love this slide. This is my fancy innovation for you here. We looked at local and provincial data on alternate level of care patients to learn about their characteristics. We did some interviews to learn about their experiences, learning that it's a difficult time. You know, it's a confusing time for patients and families and for providers, and there's lots of room for improvement in this care transition experience. So we looked at the evidence. Here's the next cog in the Learning Health System framework. And so we did a scoping review on strategies to address ALC, and we didn't find anything in the peer-reviewed literature that focused on partnering with patients, caregivers, and providers to design service improvements. So there was a gap there that we wanted to fill. So we did some co-design work. I work and continue to work with a wonderful council of ALC patients who have had ALC experience along with their family members. We worked with various groups across the province. We engaged with lots of other patients and families across Ontario, different providers, different organizations. So we cast our net really, really wide. And we co-designed a communication guide for patients, caregivers, and providers, and also an intervention which was meant to be implemented in the hospital setting. So going to the implementation side, well, our work was included in the new practice standards for alternate level of care. So that's the LEAD practices guide. It was never implemented in a hospital setting. And this is where, in hindsight, I can see what happened. So the next, the feedback was this could have been maybe smaller scale to begin with, directly integrated into processes within maybe one hospital to start, and then scaled out afterwards. And also, we didn't have a clear receptor for the co-design work we were doing. While initially it was part of a province-wide task group, that group dismantled over time. It was repurposed. So we sort of lost our policy link. And also, we weren't firmly embedded in a setting with people that said, we want to implement what you have created. And so although it went into a practice guideline, it didn't actually change practice in the hospital because we cast our net a bit too wide. And so I'll just quickly move things along. I think I have maybe 1 minute if I'm lucky. I won't go through this learning health system slide. This is just to show it's ongoing. We had a much more intentional ongoing engagement strategy, which is in one setting, which is now leading to some tangible changes. So the co-design learnings here is to ensure that there's receptors for the work that you're doing. Who is invested? Who will implement the changes? Where possible, integrate changes and innovations into existing workflows, particularly if you're working within the healthcare system, and be really explicit and intentional about the goals and scope of the work, and maybe starting at a single site and scaling out after. I think I have one more slide. So some conclusions: relationship building is critical and ongoing. Honor the diversity of expertise and acknowledge the differences in decision-making power that people have, and help prepare them to have an equal voice at the table. Involve people impacted by the problem, as well as those that are invested in making the changes, and think long-term. So co-design is an opportunity to build capacity and a learning culture for the longer term. And apologies, I went a little over, but I just wanted to say, check out our 2 webinars. We can put the links in the chat. We did these, we created these in partnership with patients, caregivers, and communities across several OHTs you may have attended on co-design. So it's about preparing for engagement and engagement methods. And I think we will take a pause there and move things along. So thank you.
Yeah, thanks so much, Kerry. Really appreciate that. So I'll just leave these up for a moment so people can have a chance, and we will post those extra pieces in the chat. And all of the materials from today that will be made available on that website that was posted in the chat for the webinars. Kerry, you know, you're clearly so experienced in this way, and I really appreciate your kind of actually leading the co-design through all of the gears, because the engagement and involvement can't just come in all of a sudden in the middle, and starting with that, building relationships. And I think that sort of builds on your early account of this. And I really appreciate your attention to thinking about where are we going with this, to what end, and then paying attention then to the next gear is implementation. And this co-design work is fine and important and essential, but unless we're paying attention to that next gear around the implementation, that has to really be part of the co-design. We will fail to quote unquote engage the gears, so to speak. I'm just wondering if you had, thank you very much. Anything that you think people kind of forget about, other than that one, maybe that one's the one that people forget about, when you've done co-design, and it's like, hey folks, we're getting a little bit ahead of ourselves at the starting point for doing this work. What's been your experience with things that people forget about as they start?
Yeah, thank you, Walter. I think, communities that surround, maybe assuming you're all working within, some of you working within organizations, the communities that surround these organizations have so much expertise, and they really know the problems that they want to solve. And when I talk about the importance of people being invested in the work to make the change, by connecting with communities to learn what are the things that they're working towards, what are their priorities, and engaging with multiple organizations within that community, there you have your receptors for the work. They have the capital to move things forward. They have the answers, and they understand the assets within their community. The way I spoke about it today was more from an institutional perspective. So say if you're making a change within a hospital setting, the receptors look a bit different. These are the people, the organizational leaders that will decide what goes forward and what doesn't. And so that engagement might look a bit different, but just not to kind of neglect the assets within the community. And I know many people know this already and do this quite well, but it's easy to forget when you're kind of locked into organizational day-to-day busyness and just trying to get things done and just trying to get through the day. It's easy to forget that there's answers in the community and great partners that want to move this forward.
Yeah, thank you very, very much. Appreciate that. And there's so much content there. I'd love to dive in a little bit further, but we also have some great examples coming up that I want to make sure we give attention to. People, if you have questions for Kerry, please pop them in the chat. Kerry's will be around to answer them, and we'll follow up afterwards as needed. I got just one more poll I'd like to just check in with now that we've started around some of this engagement on this one, which is, in your work in co-design for people participating today, we're interested in what kinds of stakeholder groups you've involved in that. So patients, caregivers, you can check all that apply in this time slate: primary care physicians, other primary care providers through teams or individual providers, specialist physicians, community care agencies. Here I'm grouping both home care services, but also community support services. And just because there's only so many lines I can put into the polls, had frontline community care providers, so not just the agencies or organizations, but those people who are actually working and meeting patients' family in the communities, voluntary organizations, and there may be others that you've engaged with as well. So you may need to scroll down to capture these, but please let us know, top choice of who it is that and what types of different stakeholders, engagement people you've involved in your work. Okay, we're going to leave it up for maybe about 10 more seconds, a couple more people clicking in here. Researchers, Deborah, thank you. I'm happy to know that. Yeah, for other types. And it is, I think, the learning health system bringing together patients, family caregivers, the health system, and researchers in collaboration is all about the three-legged stool, as Maureen Smith very often describes this. Okay, why don't we share out the results right now, and so people can all see, and you might have to scroll a little bit on your screen to see all the results, but patients at the very top, 90%, Family caregivers, 83%, really happy to see it so high. Sometimes people forget about the importance and essential contributions of caregivers. Primary care physicians, astoundingly high. So 74%, that's amazing. And other primary care in a similar vein. Community care agencies, home care, and frontline community care providers, really pleased to see that up in the, say 70% range. So all of these groups that we'd kind of identified being represented in some way, and be happy to a few more people besides Deborah clicking into that other. So please do let us know in the chat who those are. I would like now, on the next slide, we just have that's the cover, and we're going to turn it over to one of our OHT examples here, where we'll hear from Dipti Purbhoo, Laura Harild, and Frances Henderson, all joining us from the Mississauga, Ontario Health Team, Mississauga Health, and really look forward to hearing about this experience. I turn it over to you, Dipti, please.
Great. Well, thank you, everyone, and good afternoon. And it's thank you for this opportunity for Laura, myself, and Frances to share our experience of co-designing our integrated palliative care model in Mississauga Health OHT. So this slide just shows you a little bit about Mississauga Health, and that's the name of our OHT, Mississauga Health. Our vision is to improve the health and wellness of all people in our communities by connecting their care across the system. What's really critical there is the health and wellness. We're focusing on both health and wellness and across the system. You can see that our Mississauga Health has 900,000 plus in terms of our population. I think we're one of the largest OHTs. We have a lot of people in our OHT without family doctors, and we have about 40% of our population coming from our boundaries, which is really important for us to consider. And it's a very diverse population in our region. Back in 2019, when our OHT was formed, we looked at, in terms of improvement opportunities, we had identified palliative care as an improvement opportunity. And that was because we heard from partners that there was an opportunity to improve people's experiences and access to palliative care, but also the data showed that improvement in palliative care was important. Only 62% of people in our region 62% of the people in our region did not have access to palliative care. And of the people that did, only half received their services in the last 2 months. So we knew that people in our region were not getting, a lot of people in our region were not getting access to palliative care, and those that were getting access too late. And so that was the inspiration behind us making palliative care a priority in terms of our work. And so if I go to the next slide, I'm going to talk a little bit about our journey in terms of developing an integrated palliative model. So we came together as partners, and you can see that on the right-hand side of the slide, we engaged all of our partners, patients, families, caregivers, community, our hospice, our hospitals, our primary care, home care, service provider organizations, all of our partners across the care continuum, along with our Institute for Better Health, as we talked in the last poll around engaging researchers, as well as Ontario Health in terms of engaging government as well, to come together to form what we called our Palliative Care Collaborative. Together, we created a shared vision and a shared purpose in terms of what we wanted our palliative care system in Mississauga Health to look like. And so our shared vision is, together we deliver exceptional and connected palliative care every step of the way, because everyone's experience matters. Our partners came together initially as a group to co-design, and I'll talk a little bit about the co-design, to co-design the model. And now we have created a governance model which sees all of these partners coming together in what we are calling our palliative care planning table to provide ongoing strategic oversight, guidance, and decision-making support as we move towards planning the implementation of our integrated model. And then we'll provide oversight as we operate our model in future. Our objectives for our integrated model very much are twofold. We wanted to design and implement an integrated model in our region, as well as build capacity and competency in palliative care to achieve the quintuple aim outcomes in terms of improving provider experience, outcomes, and provider patient experience and outcomes, as well as ensuring equitable access to care. If I go to the next slide, This is our journey in terms of how we co-designed our integrated model of care. We looked at our current state. We knew we were delivering good care, but we knew that access was limited and it was poorly coordinated. We built upon previous work. There was a history in our region of our palliative care network coming together and doing a lot of work around palliative care. So we looked at information from the co-design sessions they held in past. We looked at using the Ontario Palliative Care Network health service delivery framework for palliative care that guides, that defines a model for how palliative care should be delivered in the community. And that's the basis of our model. And then we also looked at population health and looked at the data in terms of what the needs of our community were to help inform our model. We then undertook co-design. We held 4 sessions, co-design sessions with all of the partners that I've listed, to come together to really understand our current situation, the problem, to identify opportunities for improvement and going deep into these opportunities, and then bringing it all together to create a model for the future. We also are now moving into the planning and implementation stage. So over the last year and a half, we've been working on planning how we're going to implement and operationalize our model, and we are hoping to launch implementation in the fall. So I'll just go to the next slide. So I love this picture, and I loved, I think Kerry talked about it, collective impact. This always reminds me of collective impact when I look at all these beautiful smiling faces of all of our partners coming together, including our patients and caregivers. I will tell you, those co-design sessions we held, there was a lot of creativity, ideas, innovations, and diverse thinking that really reflects the value of bringing partners, diverse groups of partners, including patients and caregivers, together. So we had 21 organizations that attended our co-design. We had 68 people invited and 52 people attended all 4 sessions, including 5 caregivers and community members. So I'll just go to the next slide. So in terms of engaging with patients and caregivers, that's a central pillar and approach that's important to the work in Mississauga Health, including the work of our integrated palliative care work. So as we, in our integrated palliative care work, looked at how are we going to engage and co-design with patients and caregivers, we reflected on and we built upon the Declaration of Values, the Ministry of Health's Patient Family Caregiver Declaration of Values. We also built upon and sought guidance from our Mississauga Health Community Health Advisory Network. This is an advisory network of patients and caregivers who are advising the Mississauga Health OHT on ensuring that we are engaging with patients and families. And what they told us was a few things that we incorporate in terms of our engagement work. They said, ensure that you're seeking the voices, diverse voices, not just the voices of a few, but the voices of all diverse communities. Make it easy for people to participate and acknowledge and support them in that work. And so those were some of the key pieces that we took away from our Community Health Advisory Network to help inform our engagement work. So if I go to the next slide. So some people may be familiar with this. This is the International Association for Public Participation. It's a framework that provides a spectrum of the various ways that patients and families and the public could be engaged. Right from informing, consulting with them, involving them, collaborating with them, and empowering them, which is really where they are at the decision-making table. So from our perspective, what we did was we took this framework and we developed a plan for our integrated palliative care work, not in terms of designing the model, but also also for implementation and then program delivery. What are the ways that we can inform, consult, involve, and collaborate, empower our patients and caregivers through all of the co-design, implementation, and program delivery? And you'll see a slide in the appendix when the slides are sent out. On slide 19, we have our plan out there, which really articulates why are we engaging, what we hope to accomplish, what we commit to our patients and families in that engagement process, and what we will do with the feedback we receive. So if I go to the next slide. based on that framework and our plan for engagement, we incorporated engagement with patients and caregivers in multiple ways. So patients and families, patient and caregivers are empowered and are decision makers on our planning table. They have a vote, and they are key members of our planning table, along with all of our working groups that we have for our integrated model of palliative care, as well as some of the digital solutions that we are developing. And the other thing that we have done is we have provided multiple ways for patients and caregivers to engage. One of the feedback we heard from our CHAN, our Community Health Advisory Network, is people want to engage in different ways, and they have different capacities in terms of time and ability to engage. And so they challenge us to provide multiple ways. And so a couple of things that we did was we provided opportunity for caregivers just to share their story one-on-one. And we did that with the view that to hear their story, to inform our model, but also to inform current decision makers in the system who could make things better perhaps right away. And so we had Ontario Health at Home in these sessions. We had our OHT, we had partners from various organizations to hear the stories, and that was really, really powerful. We also had various focus groups where we invited folks to share their stories. And then we did interviews, particularly for diverse communities. We sought out to have one-on-one interviews to seek feedback, to make it easy for people to provide input. So again, looking at multiple ways to provide feedback, multiple ways for patients and caregivers to engage. Some of what we did in terms of engagement and some enabling strategies for us is we recruited interested patients and caregivers from our palliative providers, through the hospices, through the hospitals, through our home care providers. They identified people who would be interested in participating and providing their input. We again looked at working with our organizations that served equity deserving communities and went to them to seek feedback and input as well. And then the other thing we did, and I think Kerry touched on some of these, is we really looked at ways to make it easy for people to engage. So offered evening participation. We looked at technology in terms of the chat function, but also Zoom is better than Teams for a lot of folks. We looked at, we had a one point of contact for patients and caregivers who would follow up after every meeting. We offered patients and caregivers to write an email with their written thoughts. So just multiple ways to make it easy for people to provide feedback. The other thing we did was we offered an opportunity for recognition. I think we often forget recognition in terms of thanking our caregivers. We had 2 socials, as we call it, where we brought our caregivers together so they can connect with one another and share their experience, but also to thank them for their experiences. So these are some of the things that we did, and it really, I can't say enough in terms of hearing from the diverse voices of our patients and caregivers and the difference it has made to our model, which Laura is going to talk about now in terms of the model that we've created and how patients and caregivers' voices had informed that. So Laura, over to you.
Can you guys hear me? See me? Yes. Okay. So I'll try to get through this quickly so we have lots of time for Frances to share her experience as well. So this really just sort of what was our output, what did come from this. And so this slide really speaks to the OHT's goal of taking what was actually in our region is a system where we have all the players for palliative care, but we weren't functioning as one system. We were kind of working in parallel, or the front lines were, but the systems that govern the front lines weren't necessarily planning together. So really trying to bring us all into one umbrella with the Mississauga Health, Ontario Health team, using our provincial map, which is for palliative care, the health service delivery framework for adults residing in the community as our kind of gold standard of what we want to achieve. But the how we get there and what are the nuances of that for our region is what we co-designed with all of our partners. And I think everything Kerry shared earlier in terms of hearing from those frontline experiences really has informed the model that we created. So if you go to the next slide, this speaks to really, I'm not going to go through this in detail, but all of the key kind of chains ideas by the phase of care in the palliative care world, sort of from the point of identification through to end of life grief and bereavement, recognizing that some of those elements apply to all of these different areas in the trajectory of care, and others are really specific to a phase of care, but really working through what does this look like for us locally, what is building on existing, and what actually is new. And in the next slide, you'll see, I think we've rolled it up into 5 really key high-level points. And this really sums it up best in terms of having a process for earlier identification and all the sort of elements that we heard. It's not enough to just identify patients. You actually need a system of care that's ready to receive them. And that might look different or expanding on the existing system, which really is number 2, our integrated palliative care delivery pathway. And it's green because that's where most of our starting work is happening, because we really felt that we need to beef up our current system in order to be able to have some of these other elements be successful. And so we'll share a bit more on that phased approach of sort of navigation point person, 24/7 support, really working as a team. And we've used some of our levers in terms of existing projects that we're doing now to move this forward. The foundational building blocks, what Dipti spoke to, we need a governance structure for this work. It is new, so we've co-designed it, which is great. But in order to continue that conversation, we actually need a way of coming together to continue the conversation as we move through our change. And then the newer areas, I think things that maybe wouldn't have come out as strongly or as their own bundle if we hadn't had caregivers in the conversation were elements 4 and 5 around grief and bereavement. Again, lots of resources do exist, but the way we access them, the ability to know about them is highly variable. So really making that more consistent, as well as an entirely new caregiver pathway where we recognize in palliative care, always have that caregivers, family are a huge part of our patient unit, both in terms of supporting them through caring the patient, but this idea that actually a caregiver needs their own care plan in order to sustain them in both the emotional, the physical, and the practical journey of supporting a loved one with palliative care needs. And so this is emerged as its own work stream, which I don't think would have been there. And I'm so glad that it is, if we hadn't had our patient care partners, caregivers in the co-design. And so on the next slide, this is just sort of explaining some of the elements of our model. It's going to be a phased approach. We're not doing this all at once. And you can see the elements on the left are really where we're starting and planning to build out the rest as we go forward. On the next slide really just highlights the 4 areas where we're currently most active in terms of building that integrated care team that I highlighted before, using our home care delivery transformation through the leading projects as our key enabler to that change. Our digital collaboration tool had its own entire co-design process that was separate from the integrated model co-design, using the same elements of who we engaged and how we engaged them. And again, this governance structure, which will serve as our sort of path going forward of how do we continue to make sure we're still having these conversations, checking in. And that readiness of partners to make the change, I think has been such a key element of the success in this work and continues to be. And in the next slide, I think this is my last slide. Really, what did we learn through this process? One is that importance of working with local priorities. You can have a great idea, but if everybody else isn't kind of on board, it's less likely to have momentum. We did capitalize on previous relationships. We started our Ontario Health team in palliative care with very strong previous relationships, and that was another reason beyond the clinical need why this was a starting area for the OHT, because we had a structure, we had people used to working together, and we've continued to build on that. We've leveraged initiatives, so the Home Care Leading Project, our digital tool, these were all opportunities that presented themselves, so we've kind of helped find our path forward by leveraging those moments. Patients and caregivers have been key to better outcomes in this work and will continue to be. We're sort of in an operational moment right now, but strategically they're super key. And I think we have done things differently because of it, and will continue to do so. And this concept of leading collaboratively, this isn't any one organization's initiative. This is all of our initiative, is also key to moving this work forward. So I'm going to pass over to Frances, who I know was hoping to share a few words about her experience working with us. And thank you, Frances.
I think I'm unmuted now. Am I?
You are. We can hear you great. Thanks very much.
Okay. Good afternoon, everyone. I'm very pleased to be here. In April 2022, I was asked if I would like to participate in the co-design of an application to assist healthcare providers in creating a more connected, easier to access palliative care service for patients and their caregivers in Mississauga. I had been a long-time volunteer at Hospice Mississauga, which formerly was called Hospice of Peel and Heart House Hospice. And I had been the primary caregiver for 2 husbands who had required palliative care. It was a real honor to be asked to help the OHT. For some loved ones and friends, their final journey has been extremely difficult, and our healthcare system did not always meet their needs. Excuse me. The opportunity to be a part of the MOHT team, whose goal of making everyone's journey through a terminal illness better, was one I could not pass up. I was really heartened to see that the group's focus was to leave no one behind in providing access to a better palliative care journey. They recognize there are a good number of people that need special consideration. Those who are new to Canada, those whose first language isn't English, those who do not use computers or do not have the use of one, those who have no family nearby to help. Another special group that was added to be part of the plan are those who are suffering from incurable chronic diseases. Their palliative journey will be longer because of the complexity of their disease, and their needs for help will wax and wane. My 2 experiences as a caregiver to a terminally ill loved one were very different. In the late 1980s, pain management was very poorly handled because of the fear that the patient would become addicted to the medication. It was a huge battle then to get the doctors in or out of the hospital to change their attitude towards managing pain. Thankfully, that does not seem to be as much of a problem today. Yet I do know there still are some patients whose pain is not well controlled. The hospices do a wonderful job to ensure their patients have a peaceful, pain-free passing. And the same comfort should be available to those who choose to die at home. Over the many months of participating in this project, I became more and more impressed with the dedication of the attendees from many diverse healthcare providers to develop this integrated model of palliative care. The task of delivering exceptional palliative care across the continuum from diagnosis to end of care to post-death support would require all of those providing services to the patient to be on the same page. So the idea of a navigator who would be the hub into which all of the health services connected as needed really resonated with me. To have one person collecting the reports of the variety of services provided to a patient over the varying stages and needs of that patient would be so much more efficient. I also welcome the group's acknowledgement that the primary caregiver is an important member of the healthcare team in managing the palliative journey of the patient. When a problem arises with the patient's condition, the caregiver sees it first and can be uncertain who to call for assistance, especially if it is after working hours or on the weekend. Having that one number to call would be a great comfort at those times of great stress. And without that support, well, the ambulance is called and the patient arrives at the emergency department. And this is not a desirable consequence for the patient or the hospital. And it could be avoided in most cases with the support that an integrative palliative care service plan is designed to give. I have nothing but admiration for the medical people who have been working so hard for 2 years to bring this initiative into being. They have always invited and accepted the suggestions and comments that our small group of caregiver participants have offered, because they have understood that our part in the patient's palliative journey is an important component. Many patients want to be cared for in their home, even up to their death, and the integrated palliative care plan that is being designed or has been designed makes that more likely to happen. Who wins in this circumstance? Well, the patient, the family, the hospital, and the healthcare budget. My only frustration is that the implementation seems to be taking a little too long to be approved. Hundreds of hours of work by very knowledgeable people who are dealing with palliative care every single day should not be wasted and should not be delayed. If Ontario wants to be seen as forward-thinking, innovative, budget-conscious, this plan is a winner. There are no negative outcomes for anyone here. And I hope that those who can give the go-ahead will recognize that and approve the urgently needed integration plan for palliative care that has been developed by the MOHT so that it is in place before the end of 2024. I'm dreaming big, but I'm hoping I can I can see it done. And when I say I mean the whole group that has been working on this. We want to see it done. And I would strongly advise other OHTs that are planning changes to their care delivery to reach out to caregivers in their area and invite them to participate in your discussions and planning right from the beginning. They are the people on the front line of patient care, and their experiences will be real and valuable to you. And to any caregivers who are approached to join such teams, I hope you will. Your voice is important, and you will be heard. Thank you.
Truly, truly well said, Frances. A few comments in there, mine included, around how clearly and well articulated you've been around the value and impact of including caregivers in this work. And I really, just greatly appreciate it. A number of comments, and we do have, I did notice a number of patient-family caregivers, including participants and chairs and co-chairs from Ontario Health teams across the province. I also understand the urgency of just when we've got the work done and we know what to do now, let's just get on with it. I think that's such an essential piece. And sometimes there are Ontario Health and Ministry individuals on the calls on these events, actually fairly often. Sometimes they introduce themselves, sometimes they don't. So I hope they hear your plea to go ahead. I just want to add just one question / comment for Dipti, Laura, Frances to comment on. And it's just, when I think about this, you're doing it very well. This is not a one and done. This is ongoing, intensive, like numerous sessions. Is there a necessity to build capacity for this work, or is this something that you just happen to already have the right people around? And it's just a matter of pulling people together, or is there actually a need to build capacity? And I'll actually turn over to the next speakers right after this to pick up that question, but maybe you might have some comment on that.
I think we had some capacity. We were fortunate to have a secretary within our OHT and a project manager assigned to this work. And Anne is here on the call today, but she's been instrumental. Having that point person to support patients and caregivers, I think, is really critical. And I think it's an important investment that needs to be made. But it's also can be created within whatever capacity you have. I think it's about being intentional to ensure that that role is created and those supports are offered. But yes, we were fortunate to have that within our OHT. Laura might have additional to add to that, but
Yeah, I think in terms of the capacity building, you really have to be quite intentional. I think in terms of the patient caregiver involvement, I think we were lucky to stumble upon 4 folks who were quite willing to dive in with us for a long period of time on this piece of co-design. And I'd say the other piece we've learned that we didn't maybe articulate is these things evolve, and we know that Francis and the other folks who've joined us in the work, they all kind of find their moment to sort of say, I think the strategy is done. We're moving into operations. You know, we don't need to be in this part of the conversation. And I think we find ourselves also looking to renew and find new folks for the different type of work that we move forward in. And I think that understanding that different folks you're engaging with will, their own lives change and the work changes, and the things that need to sort of have a beginning and an end, and then understanding that new people will come through as well, I think, has been learning for us as well. And as the work changes, so does the type of person who might want to be engaging, and the type of engagement that you need also evolves.
Yeah, thank you. Wise, did you feel well supported, Francis, in this?
Yes, I did. I felt that what I offered in comments was well received, and I felt as if I was part of the team, and that was very important. And I was very grateful to have that feeling.
Great. Thank you all very much for sharing this experience in Mississauga. I think it's a model. Obviously, it's not light touch. It's quite intentional. And yeah, Dipti just said there, being intentional. There you go. It's clear. It comes across clear. So I'm going to go ahead right ahead past, these are some of the appendices that will be there, and past the polls. I basically put this question as well as the next one into the chat about the strategies to include and create inclusive environments where patients, family caregivers are heard and valued. So really appreciate maybe putting in, making sure you're texting to everyone in the chat so that people can see. And I'm going to turn it over now to Yasmin and Edward from the Mid-West Toronto Health Team here, but their experiences both in supporting capacity and also in co-design. Yasmin.
Thanks so much, Walter. And I feel like the discussion around building capacity is so important because we continue to build capacity every day in our OHT, and we're always building it for engagement. And that's also what we're going to be sharing about today, because we really wanted to speak to the evolution of co-design and engagement in the Mid-West Toronto OHT, which is our OHT. So I'm just going to start off by giving a short background on our OHT, as context is so important in OHT work. And then Edward will go over our earlier co-design work. And after that, I'll talk about the evolution of our governance model and how it exemplifies our commitment to patient and caregiver engagement. So in this slide, it's just our context slide. So for context, our OHT is located in downtown West Toronto and consists of more than 50 partner organizations across social and health sectors. So this includes 5 major tertiary hospitals. So we have CAMH, UHN, Women's College. We also have 5 community health centers, such as Access Alliance and Parkdale Queen West. We have 5 family health teams, several community service organizations, and around 400 primary care community providers. So we are a large, diverse OHT and have an attributed population of over 550,000. But most importantly, patients and caregivers are at the heart of our OHT's growth and evolution. So next slide, please. And we say that patients and caregivers are at the heart of our OHT because of the early commitment to co-designing healthcare when our OHT was formed. And I feel like this ties well into the capacity piece too, because since inception, there was a shared vision that our OHT will be stronger when we bring people with diverse lived experiences to our planning tables, and also to our highest decision-making table too. So this is our executive committee. And this was because it sets the stage for meaningful engagement and shared power. It actualizes theory into practice. And to give an example of our early commitment to co-design, Edward will go over the co-design work that our OHT undertook early on with the In Your Corner program and how it shapes our priorities. So Edward, over to you.
Thank you, Yasmin. I want to start with an acknowledgement and a regret. My acknowledgement is that the work that I'm presenting is very much on behalf of the Mid-West Toronto Ontario Health Team and Open Lab. Open Lab is a strong partner of ours and was also engaged to support our co-design work. So I'm very much reflecting the amazing work that they have done. You might also recognize them from the publication, The Local. They are a great partner in Toronto healthcare. The regret I have, and Francis, you reminded me of this, we usually like to give this presentation with one of our patient advisors, and unfortunately we're not able to have one join us today, but they are the true voice to this work. So my regrets there. A quick rundown of the mental health and substance use work to date, how this work evolved. I think right at the top, we need to share that the Mid-West Toronto OHT, the first two things we tried to figure out as a group was our governance structure and how we do co-design and how we bring in the patient and caregiver voice. So there is a high degree of intentionality with that and making sure we had a system for engagement and also making sure that all work that people with lived experience participate in is compensated at a level and fair amount. So having that in place, we were able to have the patient voice embedded throughout each of these steps here. The first one being that we selected mental health and substance use as one of our 3 priority populations, which is a task that OHTs were to take on when we first applied to become Ontario Health Teams. Then we worked with Open Lab and engaged them and sort of narrowed in on an exact population of focus and an exact area within the system that we felt we could deliver significant impact to. And that group is people who experience structural, functional, and health impacts to varying degrees as a result of their substance use and have a willingness to change. And we are looking at closing transition gaps for those individuals, so supporting them with their navigation to their desired service. From that, the work continued with Open Lab and our advisors, and we created the multi-partner navigation program, which is now affectionately termed the In Your Corner program. If anyone would like to learn more about this program, please reach out to me separately. I won't go into as much detail on the specifics of the program, except to say that it is a 24/7 navigation service where we have navigation supports across 4 organizations, and we are able to support people from their early desire need, or whether they call from a point of crisis, to a 12-week engagement to ensure that there's a warm handoff to a service that can help support challenges as a result of their substance use. Next slide, please. This is a quick visual on how the program works, but I think just summarized it to the degree I'm hoping to in this call. So I'll go to the next one, please. This is the process that we undertook with Open Lab. So this is called the Double Diamond Framework. And the reason I wanted to share this is just to hit on 2 major themes that I think emerged and that we learned about as an OHT when it comes to co-design. And the first one is that the importance of embedding the patient and caregiver voice throughout the process, both from the sense of time, but also from the level of decision-making. So decisions around what our population of focus, what our interventions are, made more at an executive and all partner level. And then there's work being done, on the ground of actually engaging with users of the service or prospective users of the service, making sure that there's an opportunity for the patient voice to be heard and participate at all levels. It's something we were able to do. So across the 4 phases of this Double Diamond Framework, we did have the patient voice really guiding us, telling us when we were right and telling us when we were wrong, and decision making and also doing the work. Next slide, please. The other, this is just some samples of the type of work that we did as part of our co-design and designing this net new service. The other theme that I wanted to address was the importance of having many different modes of participation. And Kerry spoke about this earlier on the call, is trying to get that representational voice, that collective, we were able to engage over 50 voices of people with lived experiences of substance use, because we designed different settings that people could participate in, from our executive table to our service design working group to our exploration team, then to going into the actual places where people interact and hosting focus groups and one-on-one interviews. And what was really important about the work we did is that we had the peers and the actual peer advisors leading those sessions to increase the accessibility of them. Next slide, please. It's my final slide, and I'll go quickly because I'm sure we're tight on time. But just a reminder that having the opportunity for participation from leadership down to doing the work was essential, and something that we took as a key learning that we will, is being brought from our mental health and substance use working group throughout all of the working groups of our OHT. And with that, we'll pass it back to Yasmin. Thank you.
Thanks, Edward. So now I'm going to go over the evolution of our engagement model and the rationale behind our decision making. And early on, as an OHT, a decision was made to embed patients and caregivers into several OHT tables instead of having a PFAC, so a Patient and Family Advisory Council. And this decision was made with patients and caregivers on the executive committee. And although there are benefits to having a PFAC, which I have a few listed on the screen, it wasn't the best fit for our OHT. And this is because we felt that input is often made on projects that are near final, so there's limited chance for fundamental changes, and it really requires a deep understanding of all OHT work. And it wouldn't necessarily guide our work at all stages, since input would be limited to predetermined intervals. So members of the OHT collectively felt it would be more beneficial to embed patients and caregivers as partners in conceptualizing, planning, and implementation. And this was so patients and caregivers could gain a deeper understanding of OHT work, and ultimately that would lead to richer input. Next slide, please. So what did the first engagement model, which we called the embedded model, look like in practice? So we had patients and caregivers sitting at most working groups and planning tables to advise on and advance the work of our OHT. Here, patients and caregivers are equal partners in planning and implementation. And when I say we, I mean myself and other patient and caregiver partners would sometimes meet as a group to share experiences and lessons learned, but we didn't have collective decision-making power. And then because some of the working groups and planning tables have been on hold, the patient and caregiver partners on those tables ended up stepping off, which is where a PFAC might have been beneficial. So next slide. And just to give a sense of what the embedded model looked like in practice, we can see here where the patients and caregiver partners sat at the governance and operations level. So as an example, I sat on the executive advisory committee as a patient partner, the all partners table, and the population health task force, which gave me a really rich understanding of our OHT and the work that we did, as opposed to if I was only on a PFAC. So next slide, please. So that was our old model. And even though it served our OHT well, we felt that we could further amplify the patient and caregiver voice. And although patients and caregivers like myself were on the leadership table, we were not at the highest level of leadership, which led to ongoing conversations around governance changes to create the best environment for co-design. And most importantly, patients and caregivers were a part of this conversation. So there were three of us, Mike Creek, Don Cooper, and I, that were a part of the discussion at the exec meetings around evolving our governance. And Mike and I were members of the smaller governance working group that was implemented by the exec, which we called a huddle. After that, I chaired the selection committee, where we decided to have a patient vice chair for OHT. And I'm giving a background on this process to show how creating the best environment for co-design requires flexibility and continuous adaptation. And it was also only made possible with advocacy from patient and family partners, and also support from other exec members and the secretariat like Edward, because people need to be committed to co-design for it to flourish. And in these conversations, we also decided to implement a PFAC that the patient vice chair, so myself, will chair. And we saw this as an enhancement to the embedded model. And it's what we now call our hybrid model, which I will go over in the next slide. The next slide, please. So this leads to our current state, which is what we call a hybrid model that combines the benefits of the embedded model with the benefits of a PFAC. And in practice, we have embedded patients and caregivers that were previously involved stay on their working groups and planning tables, but are now also members of the PFAC. And new patients and caregivers can choose from one of two levels of engagement. So they can either join as a member of the PFAC, or they can be embedded in a working group and planning table and also be on the PFAC. So all patients and caregivers on working groups and planning tables will automatically be a part of the PFAC. And this is so they can bring feedback to the PFAC and also have a space to share and talk about their learning. And this model is really tailored to patient and caregiver skills and needs so that they have a choice based on their availability and time commitment. And this was based off of the conversations I had with other patients and caregivers in our OHT, because some of them wanted to be more involved and had more time versus others didn't. So it's really going to be up to them. So next slide. And here is our updated model. So you can see the difference. We're going to have patients and caregivers embedded at all tables, in addition to a PFAC and a patient vice chair. And this really demonstrates our OHT's commitment to amplifying the patient and caregiver voice and creating the best environment for co-design work. So next slide. And at the core of our OHT partnership is a shared value. So we believe that designing a system that works for the most vulnerable in our communities ensures that a system will benefit everyone. And our journey through early co-design efforts, as Edward outlined, and also our recent governance changes highlight our commitment to legitimizing and amplifying the roles of patients and caregivers. And the result is a democratized leadership space with shared power and decision-making. So we encourage other OHTs to really challenge the status quo and embed patients and caregivers into the highest levels of leadership. And this approach was successful in a highly complex OHT, which, like I said before, we have 50 partners, we have a very large population, so it demonstrates its feasibility. And by doing so, we really are creating an inclusive health system that truly reflects the needs of those it serves. Thank you.
Wow, I am heartily impressed again, and as are others, and Emily just popped into the chat articulating what others are working towards, and I think sort of setting out this emblem, and I encourage others. I look forward to learning more about how well Ontario health teams are doing this more broadly. We have these examples that we brought today, but I know that there's other work happening elsewhere, and I look forward to learning more about it. Contribute in the chat, let us know. So that we can share that back out. If you have other resources, feel very welcome to email us, oht.evaluation@utoronto.ca, to let us know about those. I do have one or two questions about how you've really built this, Yasmin and Edward, but I'm afraid you won't have time to answer them within the time. So I'll hold on that and just give you greatest compliments for having, such a multi-pronged approach where you're building capability, putting people in decision-making roles, as well as doing the co-design and actually iterating and not feeling like, oh, we've got the model, we do engage, we're done. But looking at, how do we improve? How do we move up that scale in terms of early identification, problem identification, as was clearly pointed out by Edward, and then in the priority setting for the future of the OHT and embedding that structurally. So thanks to Yasmin. So I do want to thank everyone today for participating. We can move ahead a slide or two. Let us know that we have 2 more in this series. Implementations coming up in September and evaluation in October. So more to come. I'm learning a lot. Could you please share your feedback? You can either scan here, or we're going to put the link in the chat box as well, so that you can go directly. And with my last minute, I'm going to put on to the next slide just to let people know, and we're going to continue to let people know, hopefully you do know about this and have heard about it, that HSPN is one of the supporting organizations behind the North American Conference on Integrated Care, which will be taking place in Calgary in October from the 15th to 17th. And we have recently announced out the successful presentations, abstracts that have been accepted for this conference. There's a fair bit of representation from Ontario, but it's also a good place to go and learn about initiatives from in Alberta and across Canada and internationally as well. You can click there, early bird pricing for the conference. Thank you very much for joining us today. Have a fantastic rest of the day. Again, gracious thanks to all of our speakers today. I was so impressed. Kerry, Dipti, Francis, Laura, Yasmin, and finally Edward. Thank you very much for joining us. Have a fantastic afternoon. Bye-bye.